How are you doing?
I'm doing very well, thank you.
Great, thank you for coming. I'm very pleased to welcome you virtually at our university at Kiev and Polish campus, and very pleased to introduce to all of the participants who are watching us online Professor Антоніо Саррія-Сантамера, PhD, medical doctor, and Professor of Medicine and Global Health of Nazarbayev University. Also, Professor Sarraya-Santamaria is a senior fellow of the Higher Education Academy. And as all our speakers from the European Association of Health Law, Professor Антоніо Саррія-Сантамера is an internationally recognized expert in medicine, public health, and global health. And his research is focused on health systems, health quality, population health, and evidence-based health policy. And now we are very pleased to learn more about molecules, about patients, and about precision medicine and public health. Well, when we hear about those topics and public health, on one hand, some of our colleagues may be a little bit puzzled. But now we should recognize that personalized medicine or precision medicine is a public health issue. We live in very interesting times, in times when public health is not only about health systems or about sanitary and epidemiological issues, but also about healthcare innovations, implementation of healthcare innovations such as precision or personalized medicine, such as additive technologies, etc., etc. So we are very lucky to have the opportunity to listen to your presentation, and it is a great pleasure of me. Let me introduce myself. I am Radmila Hrivtsova, Professor of Public Health and Management and Vice Rector of the Kiev Medical University on Public Health. And I'm a lawyer by profession and practice an attorney who specializes on medical and pharmaceutical law and public health law. So for me, it's a real pleasure, a special pleasure to introduce you, and we are very interested in your presentation. So please, Professor Sarraya-Santamaria, you are given the floor.
Okay, let me share my screen. Okay, so good afternoon from Kazakhstan, where I'm right now. Although I'm originally Spanish, I have been living in Kazakhstan for 7 years. So it's a real pleasure, and for me, for both being in Kazakhstan but also being European, having the opportunity to share with you today this talk in which I want to discuss about personalized medicine. I want to discuss about evidence-based medicine. I want to discuss about public health under this peculiar title of molecules, patients, and population, but also focusing on an example, which is a small example, which is vitamin D. What should we do with vitamin D? Because it appears to be a simple thing, but however, it shows a different things that, especially for clinicians, who most of them are not going to work in public health, most of them will work with seeing patients, they offer reflections on what represents whether to test, not test, whether to treat, not treat patients, and how the different interactions between molecules, patients, and the population understanding may help us to have a better healthcare, focusing on understanding the molecular dimension, but also the patient interaction, but also the population health dimension of this problem, which is vitamin D. So you have a patient. The patient has diabetes. And the patient has heard that, doctor, there's a lot of information on social media that I have to check my vitamin D levels, and probably I should get a supplement. What do you think? And then you have to decide. It's a simple test. It is not will not cost millions of euros or even 100,000. The vitamin D treatment is also relatively cheap, will not be a major issue. But the question is it really something we have to do? Do we really have evidence on whether this test and the subsequent supplementation really will help the patient, this patient with diabetes, and will prevent the development of complications, will help to protect their kidney, the eyes, alleviate their neuropathy, and how, at the end, are we going to discuss with the patient what is this situation, simple situation, vitamin D, test, not to test, supplement, not to supplement, how we personally have discussed with the patient, how we provide this information in a way that the patient understands what the problem is, and at the same time, we can have a common agreement on how we proceed in this process of care with vitamin D. So, just for starting, there's a strong association between low levels of vitamin D and incidence of disease. There's a strong association between that you have low vitamin D and basically you have more health problems, to the level that has been even associated with higher mortality. Low levels of vitamin D have been associated with higher mortality. So, in principle, it appears that the obvious is, if deficiency is that's a problem, let's test and treat. Because it may be that this is relatively clear, the association between low levels and mortality. So intuitively, everybody will agree that testing and treating will be something that is necessary to do, especially in patients with diabetes that is complications. So, brief presentation of my young colleagues studying physiology about the complexity of the metabolism of vitamin D, since you get the initial products at the skin, you get the sun, then has to go to the liver has to go to the kidney, and then this activation has to be transported, and then once it's transported, have to go and have their, what are today quite clear, their immunological protective actions at the nucleus of the cells through what we call the vitamin D receptor. So this is relatively clear. We know we have to study in our physiology courses, and then what we have is, as you can see, a lot of elements that appear to be in this process, with a lot of enzymes and a lot of possibilities that this process may be affected by different molecular problems that may have small effects in the transportation, in the binding, in the action at the nucleus level, or in the activation or in the disactivation during the metabolic cycle of the vitamin D. So we also know that there are a series of factors that affect the vitamin D levels. Limited sunlight exposure, some biological demographic factors, not getting enough sunlight is clearly associated with lower levels of vitamin D. Aging is also very much associated. Obesity is also very much associated. Other medical conditions like malabsorption, bariatric surgery, or kidney and liver diseases, because the vitamin D will have to be activated in this organ. So there are a series of factors that, if you consider especially this aging and obesity, are factors that are also themselves associated with higher degree of complications in certain diseases, especially diseases like diabetes. So in this process, and I was previously mentioning, all these processes are activated by certain enzymes. These enzymes may have different genes that regulate their functioning, and different genes may have different presentations, and there may be, this is hypothetically, certain genetic difference that may have an influence on how, from the sun and diet to the liver, to the circulation, to the kidney, and finally to the vitamin D receptors, influence in determining whether this process, complex process, really works appropriately. So in diabetes, specifically vitamin D has been shown to be having effects because of pleiotropic effect that vitamin D has, not exclusively in the skeletal, in the bone metabolism through the control of parathyroid hormone. A lot of factors that are influencing the beta cell function in the pancreas, the insulin sensitivity at the peripheral organs, specifically at the kidney, because it's also related with the renin-angiotensin system, which is also so important for maintaining the appropriate functioning of or avoiding the complication kidney disease. The general immune modulation that is also typically now clearly associated with the development of diabetes and complications. So vitamin D may have a significant pleiotropic effect through different actions at different levels. So at the same time, as I was mentioned, there are different elements that may be at the genetic level having influence on how the vitamin D is activated, how the vitamin D is transported, and how the vitamin D is actually functioning to the vitamin D receptor at the cell level. So this is the introduction as a background to understand that this simple, but at the same time to some extent fascinating product has a significant complex metabolism. But then how? What we have seen is clearly demonstrated that vitamin D is associated with worse health outcome. But then the question is supplementing something that benefits patients? So again, this is a relatively recent study that collects the best evidence in terms of longitudinal studies at the general population level through a meta-analysis showing that clearly there's a higher mortality associated with lower levels of vitamin D. So the lower your levels of vitamin D, the higher the risk to develop any kind of health problem, but also even to have earlier mortality. So this is a huge problem. So again, the obvious and in principle intuitive idea is let's supplement with vitamin D. Okay, so and that's what we have seen, and this is the consistent, solid evidence, is that regardless how low your vitamin D levels are, regardless how directly associated with worse outcomes, even with more general mortality, if we supplement with vitamin D, we don't find any benefit. We don't see that patients with diabetes stop the progression and complications. And we don't see, not just for diabetic patients, but with patients with cancer, with patients with cardiovascular disease, that when we supplement with vitamin D, we observe a significant benefit in terms of real clinical outcomes. And this has been done in clinical trials. There have been a lot of meta-analysis showing that there's a clear difference between what we have found in terms of the effects in worse outcomes and what we don't find in terms of benefits in health. So there are a lot of possible explanations because, and that's also starting to discuss for my younger colleagues. Medicine is a complex art and science, but what you have to avoid is always practicing medicine based in numbers obtained from basically blood tests. So what is important is that these tests are there, you will obtain certain numbers, certain values, but you have to always observe and analyze what is the patient characteristics and how these factors that you are seeing in a blood test or any other diagnostic test really have a real effect in what is the correlation with the clinical condition of the patient. So now some results of our own research in this dimension. We have been analyzing different things in vitamin D related with health outcomes. And we did a study recently. In fact, what we are showing here are results from publications from two recent PhD students that I supervised that have recently graduated. One is a study on the progression to diabetic kidney disease in patients with diabetes. And what we analyzed is in a series of patients with diabetes, the difference in terms of the progression to diabetes kidney disease, dividing patients in those who have or not have diabetes kidney disease, and analyzing certain genetic characteristics through analysis of genotypes using SNPs. In concrete, these three SNPs that you have here. And what we found is that this presence of certain genetic characteristics, genetic variations, are associated with the development of diabetic complications in diabetic patients, while others genetic characteristics, different genotypes, protect patients from developing this complication. So, in concrete, you can see, and this is the odds ratio, and you can see here that these are the presence and carrying this type, these two mutations really protect patients versus those who don't have these mutations. Showing that and indicating that it's highly possible that in this complexity metabolic pathway that I was showing before, these genetic differences that were findings of our study can explain and determine why some patients progress to diabetic kidney disease and some patients did not. We complemented this study with another study in which we analyzed in the early phases of COVID whether certain genetic characteristics of also related with vitamin D are or not associated with having or not the infection. So in the previous case, we did not analyze vitamin D levels because in patients with diabetes with kidney disease, and we have a lot of patients also in dialysis, the vitamin D levels that we may found in this population are not really valid to measure. But in this case, in the case of COVID, we analyze also vitamin D levels. And what we found is very interesting. What we found is that the COVID infection was associated with the presence of certain genetic difference in terms of the metabolism of vitamin D, but it was not correlated with the levels of vitamin D these patients have. So if you have high levels of vitamin D, but you have certain genes, you may develop the infection, while if you have low levels of vitamin D and you have other genes, you may be protected. So this suggests that part of the differences that we were identifying in these studies that have explored and analyzed the influence of vitamin D in patients' outcomes could be modulated by the difference in genetics that patients have. So it's not so much how much vitamin D you have, but it's which genes you have. So if you have certain genetic composition, you are at risk of developing kidney disease complications, you are diabetic, or if you have certain genetic complications, you may be at risk of developing COVID. And that's not related with the values of vitamin D, but it's related with your genetic characteristics. So this is one of the lines of research of my group, and we are continuing investigating in this direction. But the question that appears when you have this information is how you translate and how you communicate and how you discuss with patients that you should or not should be receiving this vitamin D test, and or whether you should or not receive this vitamin D supplement. What we are doing in our studies regarding it's not very complex in genetics, it's of course something that cannot be done, cannot be conducted in routine clinical practice. That's not really possible. So you cannot genotype patients in routine situations in cases in conditions like diabetes. This approach of personalized medicine, genotyping patients and describing, and based on these specific differences, specificities you may find, are typically done in oncology or certain type of cancer. But that not can be done in patients with diabetes, because the volume of patients with diabetes is quite high, the volume of patients with low levels of vitamin D is quite high, but this is not really possible. So how to translate to at the patient level this problem that we are starting to realize that could be explaining the lack of effect of supplementing with vitamin D in cases in which patients have low levels of vitamin D. So we have here evidence-based medicine. And evidence-based medicine have been supporting and helping doctors taking decisions. But evidence-based medicine has a significant limitation, because evidence-based medicine is based on what we call here the tyranny of the average. So evidence-based medicine is an extremely valuable tool to help support medical decision-making, but part of the problem is that it offers solutions for the average patient. And in most occasions, for a lot of clinical conditions, this average patient does not really exist. So we take a clinical trial, we obtain the benefits, and then we have to apply this benefit based on clinical guidelines to all patients. So personalized medicine is appearing as an alternative that aims to overcome this precise limitation. And this limitation is that not all patients are the same, not all patients will respond to the same drugs, so we will have to personalize and individualize here. So this that doctors forever have been recognizing that it's a problem is, and it's how clinical practice really works, is a huge problem if we aim to apply evidence-based medicine, which is developing a guidelines, developing recommendations, and applying these recommendations. To some extent, without considering, it's never true, I'm exaggerating a little bit, but without really individualizing care at the patient level. So the question is that what we have seen is that not all patients will respond negatively to vitamin D. We know some patients will respond positively, but the main question is that as we are not going to have the capacity to genotype patients, we will have to rely on our clinical interpretation of the specific clinical situation of the patients and how to communicate with them the message that in most of cases, what we know from the evidence, and regardless we don't know exactly what is your genetic composition, it's highly unlikely that you will benefit from receiving vitamin D test and supplementing if you have a low level of vitamin D. So this is also recent meta-analysis that precisely shows what I'm saying. The evidence of the benefit of vitamin D is basically non-existent. So for the general population will not benefit from receiving vitamin D supplement. The general population will not benefit to know if their low levels of vitamin D are low or not low. So this is to some extent, and I understand, counterintuitive with the idea that low levels of vitamin D really are associated with worse outcomes. So, but when you analyze at the general level, what you find is that it's highly unlikely that patients will benefit. So this has been recognized recently by the updated guidelines from the Endocrine Society, in which they clarify two critical things. One, which is very important, that we should try to avoid using the terms vitamin D deficiency. So vitamin deficiency suggests that there's a level, a cutoff, a point, a value of vitamin D below which patients are at risk. This is not true. This is not true. There's no evidence, no study have been able to demonstrate that there's a level of vitamin D, determined level of vitamin D, that put patients at risk. What we know is that low levels of vitamin D put patients at risk, but we don't know, we cannot confirm that there's a certain specific level. So we should try to avoid the terms vitamin D deficiency. But this is very important, but suggests that patients are at risk for having low levels of vitamin D. Because the second point is that the decision to test and the decision in case of the doctor consider has to be individualized at the patient level. And in this individualization at the patient level, the doctor will have to determine, will have to consider, will have to analyze what are the specific characteristics of the patient and whether these specific characteristics of the patient really justify that the patient is at certain risk of developing complications, and discussing with the patient whether in this effective relationship and effective communication, the doctor can suggest to the patient, maybe you are benefit, but I cannot really determine with strong evidence that this is going to be the case. So the second problem, which is related with the population effect, is that as in any other problem, and this was described from Sir Geoffrey Rose when analyzing public health interventions, is that most of the cases of any problem occur not at the higher level of risk, but at the lower level of risk of the population for whatever, for cardiovascular disease or for cancer or for any other disease. Why? Because this is not about the risk, the relative risk. This is about the amount of cases that you will observe. And the majority of cases will occur at low levels of risk, not at high levels of risk. So in public health, we consider then this double perspective on how to approach providing solutions to patients. The high-risk individual strategy, in which you aim to identify the patients at high risk and identify these patients and treat them, or the population strategy. The population strategy forget about individuals and suggest interventions that are valid for the whole population. So if we go, this is also a very recent study conducted in Kazakhstan, and they still use the concept of vitamin deficiency. 57% of the Kazakh population have low levels of vitamin D. 57% of the Kazakh population. Vitamin D levels are clearly related with sun exposure, which in countries like Kazakhstan is very much a problem in a relatively large part of the country, especially during the winter, because of the extremely winter conditions. And then because probably food fortification is not really extended in the country, and this adds two critical components that really are associated with the prevalence of high levels of vitamin D at the population level. So the question here is that if we assume that this 57% of the population have low levels of vitamin D, in principle, applying this counterintuitive mechanism, we should try to identify at the population level all of them, and we should try to supplement them with vitamin D. However, what we have seen is that this is not the case. So the population strategy here seems to be the more reasonable, nevertheless not easy, and also with significant complications, which is guarantee a profit for fortification, which may require that the food industry really take it seriously, the fortification, and the other, which is a problem which is structurally complex in Kazakhstan, which is guaranteeing appropriate sun exposure, and which in winter season is relatively complex in this country. So, but what we know, and this is once again extracted from this choosing wisely, which is a movement in medicine which aims to take right decisions for patients based on how we interpret and how we analyze the evidence to use it for patients. What we know is that, and this is in lay language for patients, that it's true that a lot of people don't have enough vitamin D, and that very low vitamin D levels increase a lot of risk, of course, skeletal problems, but also other health problems. But we know, and most likely because of the complexities of the metabolic process of vitamin D and the possible genetic differences existing in any of these complex cycles, that a lot of patients will not benefit from testing and for supplement. So what can we do? to overcome this problem is to understand that something that does not benefit on average, however, will benefit someone, which is, to some extent, applying the concept of personalized medicine and overcoming what has been a significant, valid concept to develop modern medicine, which is evidence-based medicine. So what we have is a situation in which we have to identify, discuss the molecular, the individual characteristics, and the population level dimensions, and how this influence, in this case, vitamin D levels, and how these vitamin D levels have or may or not have an effect on the health of the patient, and how identifying and treating may have or not a benefit on the patient. So, as short of conclusions, a strong association is not a mandate to treat. This is what we know. There's a strong correlation. Should we treat? The evidence tells us that in some cases, patient will benefit, but in some cases, patient will not benefit. That the blood level is not an appropriate level. It's not an appropriate target. So there are a lot of factors that influence the blood levels of vitamin D, and considering vitamin D levels is something that is today not recommended, except in clinical situations. That there are most likely significant genetic influences that determine not just your level of vitamin D, but whether vitamin D may work or not work. That we have to individualize cases, and the immediate and direct applications of the average extracted from guidelines and recommendations should be cautiously applied in clinical practice. If this is complex to understand for us, the effort is how to make this complexity understandable for those who really need to understand what is the real complexity of this problem, which are the patients. So we have to be able to use one of the, probably the best instrument that doctors have, which is communication with patients. So we have to be able to transmit appropriately these complexities and recognize also our uncertainty, which to some extent is our own ignorance, whether you will benefit or not from testing and treating. So, and work with the patient to elaborate an appropriate, valid strategy for each patient, in which we share what we know, we share whatever we don't know, which is a lot, use appropriate numbers. This is an issue with clinical epidemiology. We have to use the absolute numbers, not the relative risk. We have to understand what are the values and preferences of patients, and then decide. And based on that, determine. The reality. This patient came to us, hey doctor, I've seen social media. There's a lot of messages about vitamin D. Should I get a test? Should I be treated? Reality. We don't have strong proof that vitamin D protects your kidneys. Vitamin D is typically cheap, not expensive, most likely will not create side effects, but we don't know if you are going to benefit or not. This is the reality. We can do the test. If you have low levels of vitamin D, we can start with supplements, and let's see what happens. Of course, without forgetting all the necessary care and treatments that are necessary for the patients with diabetes. So these are a series of publications that are referring to the topic I have been discussing. And just to finalize once again, thank you very much for this possibility to discuss this issue, which is something that we are working in a group that is a small thing but has significant implications. Once again, to understand and to develop an appropriate understanding what really practice medicine is, that is having a global understanding of the molecular dimension of the disease, of the patient level characteristics and the difference existing at the level, but also to understand in Kazakhstan, 57% of the population will have low levels of vitamin D. Should we start treating and supplementing everybody? Most likely people will not benefit. So how to communicate, how we transmit, how we discuss with our patients, with our population, this complexity in a way that people can understand and then make the decision they consider more appropriate for the case, and how we can then, from this perspective, support them in this process. Also, at the same time, understanding that there's still a lot of things we need to improve in our knowledge, even for this, in principle, and apparently simple thing that is vitamin D test and supplementing. So thank you very much once again for the invitation and for the opportunity to present this lecture to you today.
Thank you very much, Professor Sarraya-Santamera, for your very interesting and very thought-provoking presentation. You've raised a number of questions that are very important to consider and look through various aspects, sometimes very unexpected. So thank you very much. For a real pleasure to listen to your presentation. Again, our thanks to the European Association of Health Law for this exciting project. And we believe that we will continue cooperating with both the association and you personally. So we will be more than happy to see you once again and to communicate with you. Thank you for your time.
My pleasure.
Are there any questions from participants on the web? I am now asking our partner Houston Info that are making it possible to watch your presentations through distance platforms.
Sure.
Dear Radmila, maybe we could send the list of the question for the professor via email when all our participants we will collect the questions and we will send it to you, okay? Yeah, thank you.
Thank you very much. That would be probably the best way because we understand how busy you are. So thank you very much for devoting your time to share your the results of your research, your opinions, and of broadening our giving us a broader perspective. So thank you very much. And again, I hope to see you once again and again and again at our university.
Okay. Thank you. Bye.
Thank you.
Have a good day.
Bye.
Bye.
Thank you for all the participants. Goodbye.
Bye.
Bye-bye.